elderly population, and talk a little bit about the pathophysiology of these fractures and a little bit about anterior screw fixation for these fractures. Now, in the elderly patients, those patients over the age of 70, the most common cervical fracture is a type 2 odontoid fracture. Now, the common theory is it's due to the weak cortical and cancellous bone at the base of the dens in older patients. And I'll go through some of the histologic data that is available for this. The problem is these people get unsteady, and because the bone is weak, very simple ground level falls can lead to a fracture across the base of the dens. And the problem is, and we certainly see this in Utah with a lot of older people, that as the population ages, these fractures are going to become more and more common, and it's something we're going to have to deal with. Here's a good example. Here's a 77-year-old retired executive, quite active, skiing up in Deer Valley, takes a fairly innocuous fall, and this is what happens. He's got a type 2 fracture, and the question is, what's the best way to fix this type of fracture? Now let's just review the mechanism of injury for the various odontoid fractures. And there's really, in the early literature on these types of injuries, there was very little consensus about what caused the fracture. There were two cadaveric studies that were published in the late 70s, the first one by Althoff and the second by Mudrian, that really tried to define the mechanism. This first study that you see in the schematics on the top is really a cadaveric study where they had heads and necks that were fixed to bases, and then they could impact the heads in various manners and determine if they could get odontoid fractures. What Althoff found was that an extension and a compression injury, i.e. those fractures that, or those mechanisms that you see at the top there, led to a type 3 fracture. But then if you came off the midline and had an oblique type of blow, usually with less force, that's what led to a type 2 fracture. Mudrian found the same thing, that when you had an oblique force, the lateral mass of C1 actually acted as a hammer and could recreate a type 2 fracture. And both these authors found that less force was actually required to cause a type 2 fracture as opposed to a type 3. And that's kind of what you see. You know, I tend to see more type 3 fractures in younger patients who've had high-speed motor vehicle accidents, whereas, you know, the little old lady who's had a fall and a goose egg on one eye, that's the one who has the type 2 fracture. These mechanisms were repeated in this finite element analysis, which is from the group at the University of Iowa. Now what you see here on the right is a bunch of schematics, and the brighter the color, the higher the force, or the more force is created along that line. And what you can see is a pure extension type of injury, a pure extension at the tip of the dens, caused a lot of force sort of through the body of C2, where you would see a type 3 fracture. That's the top two lines there. That middle line there, particularly there on the left, an extension that was oblique, about 30 degrees off the midline, you had a lot of force that was created, again, right at the base of the dens, i.e. a type 2 fracture. And what you can see here is it takes a lot less force to produce a type 2 fracture than it does a type 3 fracture. So again, innocuous falls are what caused the problem. Now finally, it's the histologic data which really gives us the reason why these fractures occur at this level. These images are sagittal sections that are thin sections, sort of the Rausching type of sections, through the dens. On the left, it's a patient in their 30s, and on the right is a patient in an individual in the 70s. And what you could find, and what Amling found in these studies, was that the cortical bone in this zone 2 was very thin, about 35% of normal. And he found that there was less than 50% of the trabecular bone, a thinning of about 55% of trabecular bone in this zone 2. So that at the base of the dens in older patients, you had thinner or less trabecular bone, thinner cortical bone, and as a result there was less strength, and then even when patients fractured across this level, presumably they can't heal because there is less trabecular bone. So that's really the rationale why these fractures occur in this location. Now the problem is, what's the best way to treat this patient? Here's a 66-year-old gentleman. Again, this was a little bit healthier fella. It took a little bit more, a fall from a bicycle, to cause this fracture, which you can barely see. It's a line right there across the base of the dens. And the traditional mechanism, or method I should say, of treatment is placing this patient in a halo. The problem with halo treatment for these types of patients, and I think we've all seen this, is just simply a halo doesn't work as well as internal fixation. You can still have a significant amount of movement of these fractures. Just from laying down to sitting up, you can see how much is angled, the dens here. And in somebody that we think we've provided the most rigid external fixation for, this is going to be very hard to heal because they're really not holding in position. So in older patients, the question is external fixation really enough? Well, there was a good, actually class 2 type of paper, case-controlled study out of the University of Iowa looking at various mechanisms of treatment for type 2 fractures. What this group found, and this is all from Vince Trinellis, he found a 21-fold greater risk of non-union when patients older than 50 were treated with a halo as opposed to some sort of internal fixation, either an odontoid screw or C1-2 fusion. 21-fold greater risk of non-union. And actually, if you look through those guidelines that were published by the joint section, the AANS CNS joint section, it was one of the few guidelines that they could come up with were for elderly patients, or older patients I should say, with type 2 fractures. And they thought that patients over the age of 50 with a type 2 fracture should be considered for some sort of surgery as opposed to rigid external immobilization, even immobilization in a halo. There's more literature here to show that the best you can do really with a halo in any group is about a 60 to 70% fusion rate, and hopefully internal fixation will provide better from that. It gets even worse as you get older. The problem is, what's really the best method to achieve internal fixation? You can see here at the top there are a couple of different ways that we've played around with so far today. That you see on the left is a C1-2 transarticular screw. That on the right is actually an older gentleman I did recently with an odontoid fracture who I couldn't place an odontoid screw in, and then did this Harms type of construct, if you will, with C1 lateral masses and the C2 pars screws. The problem is you lose a lot of motion when you do these C1-2 immobilizations, and so there are some potential benefits of the other common method, which is anterior fixation or an odontoid screw. First of all, you preserve the joint motion at C1-2. In some hands, you can have shorter surgical times, though it is a lot of fiddle factor often to position these patients. There's theoretically no risk to the vertebral artery if you're putting an odontoid screw in, and you don't have to turn the patient prone, so hopefully you can avoid all those pulmonary complications that you can see in a lot of these older folks. Now, is there anything in the literature to help guide us as to which method of fixation is really the best? Well, there are a couple of studies that were published in the 90s that do give us some clues. This first one from Bednar and the group in Toronto is very interesting. This is actually a cohort study of 2 separate cohorts. Now, the thing I don't have listed here is their historical cohort was a group of patients over the age of 70 that were treated with halo immobilization or immobilization in tongs for long periods of time. And they found that in this group of patients, no surprise, they had a 40% mortality rate. So you had a 40% mortality rate with traditional treatment, i.e. immobilization with halo tongs, if you were over the age of 70. Clearly that was not acceptable to them, so then what they did is they took the next 11 patients and actually did a C1-2 fusion. They found that they had a over 90% success rate, that's patients fusing quite well, and no in-hospital mortality. So clearly early fixation is the way to go for these patients. Whether you use anterior or posterior, well, there's some other papers that try to point at this. A group from Sweden performed anterior odontoid fixation in 19 elderly patients, and they achieved bony fusion by 6 months in 16 out of the 19 patients. And the other 3 that had non-unions really didn't require any treatment. They thought they had stable or fibrous non-unions. There's no real direct comparison or no sort of class 1 evidence comparing the 2 techniques. The best that we can do here is another group from Sweden who found somewhat different conclusions than the Berlman group. And what they found was that using a posterior C1-2 transarticular technique, they had 100% fusion rates, whereas anterior screw fixation had a less than 30% success rate. The problem was a lot of these failures in the anterior group really were just subtle loosening of the screws, patients that then went on to a solid bony union, but because they had a slight change in the position of their screws, they were determined failures. So clearly these people were somewhat prejudiced against the anterior fixation of the odontoids. But really this is the only direct comparison from a single group that I could find in the literature. So I went back and looked at these patients to see if we could see were they healing and what kinds of complications did they have while they were in the hospital or while we were doing the procedure. All these patients, 40 of them, had direct anterior fixation according to Ron's technique with either 1 or 2 screws. We had 40 patients. There was a slight preponderance of females, and we had a follow-up range of up to 5 years for these patients. The 0 follow-up, those were due to patient deaths, and we had 3 of those in the immediate perioperative period. The mean follow-up for this whole group was 16 months. Now, here's the results. We can see that a couple of the patients died in the immediate perioperative period. 2 of them were MIs and 1 was a case of sepsis. There were 3 patients that made 2 follow-ups. That's only to 3 months, but they were then lost to follow-up. 26 of the remaining 34 patients, that's that's actually about 70-some%, had a bony fusion, and another 4 patients had a fibrous union. Now, if you look at those patients that are stable, those that didn't move on flexion and extension views, that's 30 out of 34 patients, or 88% of the patients were deemed stable on flexion extension views at their last follow-up. In terms of medical complications, a lot of the patients got through this procedure without any complications. We mentioned the deaths. There were a couple of other MIs. There were certainly a number of pneumonias, a couple of strokes, one pneumothorax that was not directly related to the procedure, but the care that the patient received in the hospital. What was more concerning to me, and the thing that I found in these patients, is the dysphagia that's related to this. There were a certain number of patients that had no trouble swallowing after surgery, but there were a significant number of patients, you can see here, 17 of the patients that had some sort of dysphagia after surgery. That was anywhere from a mild dysphagia that required a feeding tube for a period of time, anywhere from basically 3 weeks to 6 months in some of these patients. Clearly a significant problem. So that's almost 40% of the patients with dysphagia. In conclusion, we found that we could get a high stability rate. 88% of these patients went on to fusion, and a low incidence of revision surgery. There were no cases of late cervical myelopathy in the non-union or fibrous union group. In other words, we stabilized them enough so they could get on with their life. But unfortunately, we found a 30 to 40% incidence of dysphagia. That's significant dysphagia where we required a feeding tube, and it points to the vulnerability of these patients. So in summary, talking about type 2 fractures in the elderly, they have very thin cortical bone and weak trabecular bone, which predisposes them to the fracture. They often have an oblique extension mechanism, i.e. they fall down and have the goose egg over their eye. That's the mechanism. The stiffest construct are the transarticular screws with the posterior graft, but unfortunately you lose significant rotation. The alternative that we like to talk about and that we think is a viable alternative, if you can accept the complications and go through them with the family, is an anterior odontoid screw fixation. In many series, and in our series, we found an 80 to 90% success rate, but there are cases in which the osteoporotic bone is just not sufficient enough to take care of these patients with an odontoid screw. Well, thanks for your attention. That's a brief overview of odontoid fixation.
Can you give me a feeling for, in this population, which is the more significant morbidity? Loss of motion or loss of swallowing and challenged nutrition?
I have a personal feeling for that, and I talk about this with my patients quite significantly. I don't know if you saw that one slide I had with a Harms construct. I've gone to actually more of a posterior type of fixation in somebody who I think is very frail and will not do well with the gastrostomy or feeding tube. It is an easier surgery. You don't have the risk of vertebral artery injury, I think, to place an odontoid screw. It's because we're pretty used to doing them in younger patients. But the morbidity of a feeding tube and having a little old lady tell you that she's had her Thanksgiving dinner through a straw, basically, is not great. So I'm moving towards a little bit of a preference to doing posterior constructs in these older patients because of this data.